Thank you guys for submitting your questions on breast implants. I got a lot of questions on breast lifts. I kind of addressed that already in one of my IG stories. So if you check that out, if you still have more questions, I'll be happy to answer them. But moving on, so people ask my preferences, saline versus silicone. I like silicone. It's softer. You don't have as much rippling where you can actually see kind of like the folds of the implant in the breast. And it's a lot quicker to place in the operating room, in my opinion. How much pressure does it take to rupture an implant? It takes a fair amount of pressure, especially for a silicone implant, which brings up gummy bear implants. So the gummy bear implant is just a more cohesive or more kind of like gel together implant. And so you can actually slice the implant in the middle and turn it upside down and it doesn't leak out. It's almost like a gummy bear. If you were to cut a gummy bear, it doesn't spill, the silicone doesn't spill out. So I like those. They're a little bit firmer than a non-gummy bear silicone implant, but it's just more of, a psychological thing. If you would like to know, if your implant is ruptured, that you're not dealing with silicone kind of leaking in your breast pocket. Nipple sensation. So it's not uncommon to have some nipple sensation changes. If the implants are placed underneath the muscle, those sensation changes should be just transient or, just temporary because you're not really interrupting a lot of the nerves that provide sensation to the nipple. Dual plane versus total submuscular coverage. So submuscular coverage, you're putting the implant under nothing but muscle. You're only limited in the size of the implant you can put in there because to put a bigger implant in there, you would need to stretch out the muscle. And that's where tissue expanders come into play. And usually you do that with breast reconstruction patients. Dual plane helps because it gives you a little bit more lower pole fullness. And if you have like a constricted or shortened lower pole, it helps stretch that pole out. So it gives you a more rounded, full looking breast. Breastfeeding, if your implant is placed submuscular, you should be able to breastfeed without any problems because you don't interrupt any of the milk ducts in the breast. Also, studies have shown that there's more silicone in formula milk versus a woman that breastfeeds with silicone implants. So you should definitely be able to breastfeed. Fat transfer. So a lot of aesthetic surgeons are using patients' own fat to put into the breast. It's a little bit controversial, but it's becoming more and more routine. Usually you see it in breast reconstructive patients to give them more upper pole fullness. I've done it a lot in breast reconstructive realm, but not much from a cosmetic standpoint. But it is becoming more commonplace and it does work. It does have limitations though, some of the risks being that if you put too much fat in at one time, that fat doesn't get enough blood to continue to stay alive, and so it necroses and becomes like hard lumps in your breast. So yeah. Incisions, so that you can almost put an incision anywhere to put in an implant, but you're only limited to mostly saline implants because you have to be able to inflate the implant. So there's some people that put in implants through the belly button, through the armpit, but those people usually have saline implants because you can't put in a silicone implant from the armpit or from the belly button. I prefer the below the breast incision. It hides well. You're able to put in larger implants and you can control how the breast looks afterwards, like when you're making the pocket for the implant. Insurance coverage, so breast augmentations aren't covered by insurance. The only way that you can have something similar would be if you are a breast cancer survivor. That's the only way insurance will pay for an augmentation, and from that standpoint, it's considered reconstruction. Breast implant illness, so I know this has been like a hot topic for like over 20 to 30 years. Back in the 90s, there was a moratorium where the FDA wouldn't allow any sale of silicone implants because there was this thought that it was causing a lot of autoimmune and connective tissue diseases. Well, that was found out to be false. There's no literature that supports any type of autoimmune or systemic diseases from silicone implants. So, if it's not evidence-based, then, I can't really speak on, that it's really just subjective and what they call I don't know. You just gotta watch the blogs because some people kind of misconstrue things. Imaging. So implants do not make it harder for cancer detection. There are certain views and mammograms that can do called Eklund views, EKLUND, which allow the radiologist to see the whole breast with an implant placed. Studies have shown that women that do have implants detect breast cancer a lot sooner than someone that doesn't have implants. And there's different reasons why via mammograms. How often should they be replaced? So if you're not having any issues, I tell my patients just to continue living their life as long as they're, after a certain amount of years, seeing me every 3 years or every 2 years to be evaluated, then there's no real need to go ahead and take that implant out any sooner. Let's see, capsular contracture. So people talked about rejection of an implant. So there's no real rejection, but the body can form a scar tissue around the implant that becomes really tough and painful and can actually distort the breast, called capsular contracture. Some of the ways to prevent that is not touching the implant when you're inserting the implant, using a device called a Keloid funnel, which is what I use, the no hands technique a lot of people talk about. Washing the breast pocket out in the implant with triple antibiotic solution with betadine has also helped, which I do in my practice as well. Let's see. Keloids and scars. So unfortunately, if you are prone for keloids or hypertrophic scars or really bad scarring, there's no real difference in the incisions versus placements that's gonna really prevent that. Only thing you can really do is try to get a good closure from a surgeon standpoint. But if you're prone to developing very keloids and things like that, there's nothing that you can honestly really do to prevent that outside of normal scar therapies with either silicone gel or injecting steroids and stuff like that. Athletic women. So yeah, there was a question about, putting the implants on top of the muscle or underneath the muscle for athletic women. If you are a bikini model and you're going to be flexing your pec muscle a lot, your pec muscle can move the implant. So putting it on top of the muscle may behoove you. The only thing is it increases your chance of capsular contracture, that scarring phenomenon we were talking about earlier. But there are a lot of fitness models that still have their implant under the muscle. And as you lose body mass for these competitions, you do run the risk of your implant being more noticeable because you don't have that fat covering the implant if it's on top of the muscle. Someone talked about having a natural look with breast reconstruction after a mastectomy. So the most natural look, to the point where you almost don't even know they've had breast reconstruction, is if you have a nipple sparing mastectomy. You would have to talk to a breast surgeon to see if you are a qualified candidate for that. That procedure is more difficult. There's a higher complication rate, but the results are amazing. It almost looks like they never had a mastectomy in the first place. But a nipple sparing mastectomy, but you have to consult a breast surgeon to see if you're a candidate for that. The reconstruction is a little bit more difficult and has higher complication rate, but it's a gorgeous surgery. Recovery time, especially for athletic people, I tell my patients 6 weeks minimum. That gives time for a kind of like the scarring to kind of settle down. Some of the swelling will be decreased as well, but really you just want that incision to kind of be scarred down because you don't want to be doing too much movement before your incisions are completely healed. And at that point, I release them out to the wild to do whatever they were doing prior to surgery. These are some really good questions. I'll try to address some of the breast lift questions that may have not been answered in my breast lift posts. Thank you guys for submitting questions. Continue to be safe. And also, I'm sorry if I couldn't address some questions because they were too patient specific or personal in nature. If you click on my link tree, there is a number to my office where you can schedule a consultation. Also, when looking for a plastic surgeon, make sure they're either board eligible or board certified by the American Board of Plastic Surgery. That way you're getting the most up-to-date and latest information during your consultation. All right, bye.